Next projection that we're going to do is a PA chest X-ray, okay? This is about to be 50% of your life minimum unless you're going into orthopedic. So, pay attention. Over. So, I'm going to have my patient face PA. The centering for this is at the level of T7. That can be easily identified by finding the inferior angle of the scapula. Also, if you put the top of the IR 1.5 to 2 inches above the shoulders, you will automatically line up to approximately T7 on an average sized adult. So that's what I choose to do. So, I have my 14 by 17 inch cassette in. I am lengthwise right now. It is totally variant on your patient if you'll be lengthwise or crosswise. Most patients will fit lengthwise on a cassette. You guys will get used to knowing if you have to go between lengthwise and crosswise. Broader patients in general may need the crosswise cassette. And by broader, I don't mean by heavier patients. I mean genuinely who have a more broader stature. Heavy patients, heavy people such as myself even, this is all soft tissue. There's a small skeleton inside of me. So it's totally based on actual bone and structure of the patient, not just the soft tissue surrounding, okay? So I'm leaving mine lengthwise for Chris. I could go ahead and switch it to crosswise for him, but I feel like I will be fine doing him on a lengthwise cassette. So I'm going to align my CR to match my Bucky and get to 72 inches because for chest x-rays we are always using a 72 inch SID. In today's world, you're generally speaking going to have handlebars on either side of the equipment. We don't have that here, so I'm going to have him roll his shoulders forward or hug the board. Your Maros tells you to do chicken wings, that's fine, whatever works for you. But again, in the real world, there's going to be handlebars. The one thing to be very careful of, especially I see this a lot with our geriatric patients, patients want to hold this. This is not stable, this is your Bucky. So make sure that if they are holding on to that, that you direct their hands farther back to the actual handlebars or even to the back of the Bucky if you work in a facility that also doesn't have handles. Make sure that the center of your patient's body is centered on the IR. Getting the patient as close as you can, but keeping them erect. We don't want them leaning anteriorly forward. Pre-warning, this chin rest is for someone with an outrageously long neck. Almost nobody naturally is going to fit their chin up on that chin rest comfortably. Chris likes to be a show-off, so he just has a weirdly long neck, apparently. That's fine. So we're going to have him positioned like this. The other thing that I like to do before I take my image is I like to coach my patients on the breathing technique. Chest projections are done at second full inspiration so that you get adequate lung filling of air. But the big thing that can happen is when you tell people to take in a deep breath, a lot of times what happens is they bring those shoulders up really high, okay? That can bring the apices of the lung field outside of your actual collimated area. So what I like to do when I have my light field on, I'm gonna have my patient go ahead and take in a deep breath for me. Blow it all the way out, okay? One more time, I want you to take in a deep breath, but try to keep your shoulders as low as possible. Take in a deep breath, perfect, blow it all the way out. So that second time when I held his shoulders, instead of going up like he did in the first image, he actually expanded his lungs out, which is what I want to happen. So when you're working with somebody, if it feels like they're starting to go up and down, put your hands softly on their shoulders. Don't push their shoulders down, but just keep your hand there as a reminder that they're there and you want to keep them there. And that will get their breathing technique to an area that you'd like. I'm going to take my left marker. I always use my left marker with my PA chest x-rays simply because we're going to do our left lateral following and I don't have to worry about switching back and forth. I also do this because when I do my AP chest x-rays, I like to have a pattern of using my right marker. That way if I ever do a series and for whatever reason my cassettes get messed up, because I've always maintained the same structure of using left for PA and right for AP, I never have to question what projection I'm looking at. I can know simply by having my marker left or right, which projection is for which breathing technique or patient position. So, left marker on the left side of the patient, light field, checking all of my fundamentals one more time. I got my 72-inch SID. I have him centered to at the level of T7. I have the light field 1.5 to 2 inches above his shoulders. And I have everything out of the way, so I'm going to start walking back to my console. I'm going to have you taking a deep breath. Blow it all the way out. Taking a second deep breath for me, and hold your breath. And I would expose the image. Moving from my PA chest X-ray, I'm going to do my lateral chest. So first things first, I'm just going to turn my patient lateral. I was never told this until I went out to clinical, so I'm going to tell you this little trick now. Whenever you're going from PA to AP, or PA to lateral, granted, your book does not tell you this, so do not put this on your boards exam, kids. Just do it in life. When going from PA to lateral, move your bucky down just about an inch. Just a hair. Touch the tube, touch the bucky. So realign that. The reason for that is you're turning your patient lateral. The right side of the patient now is going to be magnified. The hemidiaphragms or the costophrenic angles in particular are going to be situated lower than they were on your AP or PA. If I did my PA and my costophrenic angles previously came just to the bottom of my image, if I don't lower this about an inch on my lateral, I will clip that anatomy and have to redo my image. I don't want to tell you how many times I had to repeat images when I was in clinical until I was taught that trick. So between your PA image and your lateral image, go down about an inch. Okay? So, I have my patient in lateral position. I still have my cassette in lengthwise, 14 by 17. I'm going to be using my left marker because the left side of the patient is down. And I like to come to the side of the patient. And I am going to just have you move forward with your feet as well. Take your feet forward. Always have your patient move their feet because your feet is your center of gravity. Well, okay, your center of gravity is technically out sacral too. But your feet are your foundation. So if you're standing and someone leans you forward like this, you're going to stay there about as long as they're paying attention to you, and as the patient walks back to the console, they're going to rock back. So at any projection that you do, keep your feet under the patient's shoulders. The feet and the shoulders should be on the same plane. That's where they're going to stay. That's their homing center point, okay? So, hands on your head, please. This is exactly what I wanted him to do, but he almost hit me in the head. This is not okay, okay? You need to take the patient's arms and bring them together. If he's spread out like a monarch butterfly, I'm going to have a huge piece of OID here, okay? OID is the distance between your IR and the patient part, so that's going to magnify that a lot. I want your arms coming in, and you want the patient to be as close to that tube as you can, or as close to that bucky as it can be, for the least amount of magnification. Then being very careful, up here, not here, up here. And still be careful with that. Always let people know where you're going to be touching them. You can't assume anyone's going to be comfortable with having hands up here, so just let them know I'm going to feel you for some landmarks on your chest to make sure that you're straight. Most people are going to be fine with that, but just don't assume, okay? One hand on the back, one hand on the upper chest wall. Make sure your hands are parallel to one another. That's just to make sure that they're really nice and straight. People can be rotated slightly, and by having your hands on either side of the patient, you can really make sure and identify that the patient's straight up and down really nicely. Okay? I'm going to hit my light field. You're going to be on the MCP, approximately the level of T7 still, even with that little adjustment that we made by going down an inch. It's going to be technically probably around T8, but that's okay. Bring these arms together. See how quickly they like to go back out to butterfly? Don't let it happen. Again, in reality, usually there's something for them to hold on to, but if there's not, this works. Make sure that you got some light field behind the patient. Be aware, especially with your larger chested women or anybody that has a little bit of a belly on them, be aware of the fact that, I'm just putting my marker down back here within the light field, but not within anatomy. Be aware that this is your lung field, okay? Your lung field's not going to sit within the breast tissue. It's not going to sit within the abdominal tissue. It's right in that rib area. So one thing that's really easy to do, especially when you're first starting out, is people center to your soft tissue areas. Don't do that. Focus on this armpit line. Your axilla is going to be true to approximately your MCP. So line up with that axilla and be confident in your centering. Patient body habitus isn't going to change where that skeleton lives. It's just going to kind of give you tricks about where you think you're actually centering. Okay? So still lined up good. We have the marker down. We're happy with our centering. This looks like it's cutting off, but remember, the farther away the patient is, the light field's going to appear smaller. It's still expanding and going through that whole patient body habitus part. Still second full inspiration on this image. So I would have my patient taking a deep breath, blow it all the way out. Taking a second deep breath for me. Hold your breath. And that's a left lateral chest X-ray. So next projection that we're going to do is an AP chest X-ray that's done in a wheelchair. Ideally, if I had a stretcher, I would do it on a stretcher for you guys, but this is what I have to work with. In reality, you're probably going to have an overhead tube, so you're going to have a lot more free range with this position than I currently have with this tube, but it will do fine for getting the concept down. So AP chest X-rays are primarily only done for patients who are not able to stand, whether that's because they're a fall risk, they're unconscious. Any number of reasons can be why we wouldn't stand a patient for a chest X-ray. It's always preferred to do it PA when possible, but if we can't, we do a AP chest X-ray. So the first thing that you have to know is that you're going to probably need some sort of sheet. Usually when a patient comes down from the ER or from their room, if you're working in a hospital setting, which is primarily when this happens, they will have sheets with them. But if they don't, you want to make sure that you take a pillowcase or something of that nature and put a level of separation between the board and the patient. These boards are cold and hard and uncomfortable, and especially with our geriatric patients, if you don't leave a level of separation between their skin line and the cassette, there's a decent possibility that you will actually tear the skin, okay? So if you were working with somebody else, what you would want to do is have both of you pull the patient up. They're probably not super mobile if you're doing the AP, but I'm going to let Chris lean himself up for me since he is. Okay, go ahead and lean back, cold hard board. You always want to let the patient know they're going back on a cold hard board. A lot of them will still gasp, but you want to know if something's going to be kind of shocking. So I have the board behind the patient's back. You want to stand in front of the patient for a moment to make sure that this looks even on both sides so that it's actually centered to the center of the chest wall. Oftentimes when you place it behind, you're going to be varying your cassette from one side to the other, and you might have a little bit of tilt to it. So you're just going to grab the cassette. Go ahead and lean back. Good. And adjust it as you need to make sure that your top of the IR is 2 inches above the shoulder, the same way that you want it to be for your standard chest X-ray. Another thing to be really careful of, because you're not working with a hard surface like the Bucky, is that your IR isn't rotated or tilted. If that's happening, if the IR has any rotation to it, it's going to make your part look elongated and tilted as well. So you also want to make sure that this board is very straight and flush against itself, or as much as possible. Okay? I'm going to take a step back, and I'm going to move it one more time just because I'm picky. Okay, go ahead and back. Go right there. Okay. That'll do. I'm going to have my markers ready to go. Steal the right one that I had for the last projection set we did. The last thing that you want to think about when you're doing this is the CR angle. You don't want to have a perpendicular beam that you generally would have for a PA chest X-ray, because if you do have a regular perpendicular beam, what actually ends up happening is you're going to project what looks to be a cephalic angle on your image. And let me explain that. So typically speaking, our IR is straight up and down. There's no rotation to it. But when we have somebody in a wheelchair or in a hospital bed, there's going to be a little bit of angle to the IR. Even the slightest bit is going to project our lungs at a slightly different angle. So we want our CR to be perpendicular to the angle of the IR. Meaning, for your AP images, you're always going to have a very slight caudal angle to your projection. I always like to start low so I'm not blinding my patient whenever possible. And then just go and open up that light field wherever you can. Then make sure that you have this centered right on the MSP. Once you do that, if you need to move your IR again a little bit so that it's equal, you can go ahead and do that. Lean back as far as you can, please. Okay. And one thing I'm going to do actually, because this is a very small wheelchair, and I cannot take out this back piece, is I'm going to have you lean forward one more time. And I'm going to put a sponge behind there. Lean back forward a little bit more. Okay, right back down. And that's going to give me a little bit more control with my IR. Before it was going back and forth because of the bars here. By me putting this soft sponge behind, I can get the sponge to stay in its place a little bit better, get it to stay straight. Okay. I'm going to work my collimation down so it's just the size of the IR. There's no reason, for example, to be taking a picture like this, that collimated field. That's going to make your image lose its detail, and I don't need a picture of half of his face. The IR isn't there, I don't need that. So make sure you collimate to the actual IR size. Have your patients elevate the chin just slightly. Especially if you have patients that are unconscious, you might need to get a partner to dress up in lead and help hold the patient's head back so that the chin isn't going into the apices of the lungs. And then just have your patient move the arms off to the side so that they're not going to be within the lung field. I'm going to take one more step back, look at my image, make sure that the CR looks perpendicular to my IR, make sure that I get my marker on. 72 inches for the SID on this image. Make sure that you identify your sides correctly. This is the right side of my patient, putting the right marker on. I would go back. I would have my patient taking a deep breath. Blow it all the way out. Taking a second deep breath for me and hold your breath. You can expose your image and you would have an AP chest X-ray.